most exciting session of the conference, that is the mega quiz. I request the organizers and Dr. Vikas Talreja, Consultant Medical Oncology, Regency, Kanpur, to take over, please.
Thank you again for the kind introduction. A very learned conference, I must say, and a very carefully selected agenda. I must congratulate the organizers for a brilliant piece of work that they've put together. And really, it feels enlightened to be at the end of this discussion. So I would be also feeling the same as all the people who have come and participated for the same. Now, best of luck for all those students who are waiting for the most awaiting part, exciting part of the conference, the mega quiz for it. And may I have the slide, please? Next. Yeah. So the first question is the grade 2 maculopapular rash management of the patients on immunotherapy includes all of the following therapy management, except you have to continue the immunotherapy. You have to take an urgent dermatological consultations, consider the biopsy, treat with the high potency topical steroids at the affected areas, or use prednisolone 0.5 milligram per kg per day. So you have to use all these management except immunotherapy is it 375 milligram per meter square every week, 375 milligram per meter square every 3 week, 1000 milligram flat dose every week, 1000 milligram flat dose every 2 week. What is grade 2 vision change with immunotherapy? Is it 20 by 200 vision? Is it 20 by 40 vision or the better one? The 20 by 40 vision or the worse one? Or 20 by 100 vision? So you have to interpret this checkmate 227 part 2 result, where the primary endpoint of the overall survival with Nivo plus chemo versus the chemo in patients with non-squamous non-small cell lung cancer histology was taken. And you could see the hazard ratio of 0.86, and you could see the separation of those curves with a p-value of 0.1859. So considering this curve, it looks like a positive trial as hazard ratio is 0.86, but control arm should have been different as compared to the chemo here. It is a negative trial as curves merge in the end. The positive trial as the improvement of OS is more than 3 months. The control arm had 15.8 while the Nivo plus chemo arm had the 18.8 months. And again, it's a negative trial because the pre-specified p-value was 0.044. Now, which of the following is the predictive as well as the prognostic molecular marker in various trials in immuno-oncology? It is a PD-L1 expression. Is it a tumor mutation burden? Is it a T cell repertoire clonality change, or it's a T cell inflamed microenvironment? Which of the following is a pan ALK, ROS, NTRK inhibitor? So which of these following molecules has an activity across all these three mutation types? Is it a reprotinib? Is it a lerotrectinib? Is it mericitinib? Or is it foritinib? Which of the following drugs work in the MET-Exon 14 skipping mutations but not in the MET amplification? Crizotinib, capmatinib, glisatinib, tipotinib. Now, the dose of the BRAF V6 inhibitor, encorafenib and binimetinib, is 300 milligram, which comes in the form of 75 milligram, 4 capsules to be taken once daily, with binimetinib being 30 milligram, which comes in 15 milligram, 2 tablets twice daily. Is it 450 milligram, 75 milligram again, 6 capsules once daily, or 45 milligram, 15 milligram, 3 tablets PD? 750 milligram, 75 milligram, 10 capsules once daily, 60 milligram, 15 milligram, 4 tablets PD? Or is it the 600 milligram, 75 milligram, 8 capsules OD, or 30 milligram, 15 milligram, 2 tablets PD? Now, the Ttmb cut point for the clinical utility for the overall survival for all the Keynote trials. It is a tumor mutation burden, which I'm talking about. So what is the cut point for the tumor mutation burden across all Keynote, that is the pembrolizumab trials, which we see? Is it the 13 mutation per megabase pair by the Foundation 1 platform? Or is it the 10 mutations per megabase pair by the Foundation 1 platform again? Is it 175 mutations for the whole exome by the whole exome sequencing platform? Or is it the 18 mutations per the whole exome by the whole exome sequencing platform? Now, e-cigarette or the vaping products associated lung injury is caused by the vaping tetrahydrocannabinol, nicotine. Is it the vitamin E or is the chewing content in that? Now, which of the following drugs is not used in the steroid refractory myo or pericarditis due to immunotherapies? ATG, azathioprine, mycophenolate, intravenous immunoglobulin. You have to mention the drug that is being crossed here. That is, it is a 1-methyl D-tryptophan inhibitor. Is it the ipacodostat? Is it the ulixertinib? Is it the venetoclax? Is it the midostaurin? Now, IFCT 302, which was a randomized trial post-surgery on follow-up, demonstrated that there is no difference between doing an X-ray or CT on follow-up in survival outcomes. Now, if you do CT scan, you get an earlier diagnosis of the recurrences and hence the survival benefit. If you do an earlier diagnosis of the recurrences and the secondary primers and primary cancers, you could diagnose them and hence you can get an overall survival benefit. Only the early diagnosis of the secondary primary cancers and hence the survival benefit. Across the trials, which of the following drug has the highest 1-year overall survival rates in the third line and beyond small cell lung cancer? Is it the nivolumab, pembrolizumab, enlotinib, rovalputuzumab, tessarine? Which of the following abstracts presented in ASCO had a positive results this year? So it was a high dose twice daily thoracic radiotherapy in limited stage small cell lung cancer. Is it the durvalumab and the tremelimumab with chemotherapy combination as the first line extensive disease small cell lung cancer? The dinuximab anti-GD21 plus irinotecan in second line extensive stage small cell lung cancer, or is it the Keynote 64 pembrolizumab trial in the first line extensive disease small cell lung cancer? Thank you for your participation. I hope everybody has got every answers right. Any problems, you can mail me anytime. And thank you for the opportunity, and back to the organizers for a wonderful conference.
Yeah, thank you, Vikas. Nice to see you, first of all. And uh, I mean, actually, he's a quiz master. Dr. Akhil. So we have many quiz masters, basically having this at all these meetings. So now this is the last thing of this conference. Vote of thanks, and definitely no conference is complete without the participation of all the faculties and delegates. So at the outset, I would like to thank all the faculty members which has actually made this conference successful, and all the delegates who were present physically or on the uh, were present virtually. So who actually are most important thing uh, in this particular conference. Uh, the scientific partners were Roche, AstraZeneca, MSD, Novartis, Eli Lilly, Pfizer, Dr. Reddy's, BMS, Glenmark, Abbott, MCure, Zydus, Intas Oncology, Phobes Care, Alchem, MedGenome, Cipla, Cadila, Guardant, Premos Life Sciences, Sun Oncology, BD, and Nelvin Life Sciences. So I thanks all scientific partners without whom this conference are not possible. Thank you for your unconditional support. Next, I would like to thank Dr. Kumar Prabhash, sir, who is basically all these meetings are the brainchild of Dr. Kumar Prabhash and definitely his dreams. Thank you, Dr. Vanita Madam. Thank you, Dr. Vijay Patil. And thank you all organizing team members, basically, who are most important. And lastly, not but the least, especially the Team Horizon, basically, which is I think always plays very pivotal role in conducting these conferences, arranging all logistics basically towards these conferences, and coordinating between all faculty members as delegates. And lastly, but not but the least, for the excellent arrangement made by Hotel Sahara Star and team. So with this, I thank you again all. If anyone I would miss, again, sincere apologies for the same. And I think we'll conclude these sessions. Thank you very much. So following this, we have actually TMH alumni meet, which people can arrange either physically or virtually. So the Zoom link already has been sent for the same. हाँ सर यहाँ पे आ जाओ। प्रभात आ जाए टीम होराइजन का बोला ना